first 3 years of coming here and faculty, I watched the film.
Good morning, everybody. Thank you all for coming. It is my pleasure to introduce Dr. Mary Armanios, who will be speaking to us about telomeres and age-related disease, how telomere biology informs clinical paradigm. Dr. Armanios went to medical school at Ohio State and graduated and did a residency in medicine and pediatrics at Ohio State, and then came to Hopkins to do a fellowship in oncology. She then stayed on to do a research fellowship in genetics, and then stayed on as faculty and moved up to the ranks of professor of oncology since 2005. Her interest has been in telomere diseases, diseases associated with telomere length abnormalities. She is professor of oncology and genetic medicine at the Hopkins University, and her program is focused on the understanding of the role of telomeres and telomerase in human disease. She's defined the spectrum, genetic basis, and underlying mechanism that mediates the short and long telomere syndromes. Her work has led to the fundamental understanding and change in clinical practice for patients with idiopathic pulmonary fibrosis, which we treat here, and cancer predisposition. Since 2019, she's the director of the Telomere Center at Hopkins, and actually runs the only lab that screens for diseases associated with telomere length disease. She has amassed more than 10,000 patients in the telomere clinic. And she has published with NIH funding in this disease over the years. These diseases are common diseases like COPD and smokers with COPD and certain cancers and pulmonary fibrosis, and she's also published in scleroderma and pulmonary fibrosis, which is why I invited her to speak. So Dr. Armanios, thank you for coming.
Good morning, everybody, and thank you, Dr. Shu, for this wonderful invitation. It's been great to be here, and I can feel how exciting it is to train at a place like this, and being at Medicine Grand Rounds is a lot more rewarding for me because I trained clinically, as you heard, and my foray into science came later in my career. Today I'm going to be talking with you about telomeres, but within the lens of how talking with patients, I think this example and this archetype shows that we can still learn from patients. So when I heard about telomeres after finishing the MedPeds residency, they were mostly in the news. People knew that they were repetitive DNA sequences that defined chromosome boundaries. People knew that they shortened with age and that caused cellular senescence and apoptosis, and that this had something to do with aging. But I had never heard of them in any of my training, even though when you go to National Geographic or Scientific American, they were often on the front pages, people claiming extraordinary things that didn't make a lot of sense at the time. And I hope you'll hear that they are fundamental to understanding a lot of common disease processes. This is the enzyme that lengthens telomeres. It's a polymerase. It's a reverse transcriptase. It adds new telomere repeats onto the 3' ends of chromosomes using a template within a telomerase RNA that's part of this enzyme. And when I started, after my clinical fellowship training, telomerase was mostly known for being upregulated in cancer and for being something you want to kill in cancer. That effort has not materialized, and I think the story that you've heard is mostly about understanding disease etiology, understanding pathophysiology, and understanding mechanisms of aging. And my introduction came from meeting this young man. I was a fellow at the time, and he came to hematology clinic. He was visible in the clinic because he had a gray forelock. And he came in because he had aplastic anemia. His platelet count was 9. he had been transfusion dependent, and he came for a second opinion because he had idiopathic aplastic anemia. But in his family, something notable came out that he not only had aplastic anemia, but everyone, basically all the adults in his family, had pulmonary fibrosis. His grandmother, in fact, had died waiting for a lung transplant for IPF, even without a lung biopsy. And what was interesting in this family is it showed genetic anticipation, where people got shorter and shorter in height. With every generation, people became gray earlier and earlier with every generation, and their blood counts were lower with every generation. And this pattern had been described in the telomerase knockout mouse that the mentor I was working with at the time had generated. And we wondered if this family could also have a telomere problem. And this was a very short case report that was very difficult to publish, but we identified a TERT mutation in this family, and nobody believed that this pattern would be reproducible. But I'll tell you now, this is the most common of premature aging syndromes, and this ended up being an archetype for understanding this much more common disease that we know about in internal medicine, where the lung becomes increasingly scarred, seemingly out of the blue. It's progressive, it's age-related, it's familial, and IPF, or pulmonary fibrosis in general, is thought to be more familial than breast cancer, and up to 20% of individuals with this condition have an affected first-degree family member. And as you probably know, it's very common. No medical therapies have been shown to improve survival. And using that first family, we did a crazy experiment where we found families with IPF, and they had been collected in registries. This one was in Vanderbilt. And I did the only experiment I knew how to do at the time, which was just sequence the telomerase genes. And it ended up being that almost 10% at the time had mutations in either of the genes that encode the TERT gene or the telomerase RNA gene. And I'll just pause to tell you that nobody believed this at the time from the pulmonary community, because I was an oncology fellow, as you heard. My mentor was a basic scientist. And also nobody believed it at the time because people were in their 60s and 70s when they developed this autosomal dominant inherited syndrome. And this is indeed one of the most common adult onset Mendelian disorders that are known. But now we can for sure affirm that this is the main pathway that we understand that leads to pulmonary fibrosis, to idiopathic pulmonary fibrosis and related conditions, and I'll talk about those. So up to a third of familial cases of pulmonary fibrosis are attributable to a gene in the telomere pathway, with TERT being the BRCA1 of this condition, if you think of breast cancer heritability. But you might know that BRCA1 and 2 explain only 5% of the heritability of breast cancer. This is a much larger percentage, which means and has meant that genetic testing and sequencing and variant interpretation of all sorts has to somehow bridge the gap from cancer, where we are used to using these paradigms, to all other fields in medicine. So just briefly, this is the telomerase enzyme. This is a little bit more caricatured figure. Here's the end of the telomere, and the mutations we have identified affect the telomerase enzyme biogenesis. It affects its recruitment to the telomere, in addition to affecting the enzyme itself. And what has made this discovery that we made now many years ago really important is the fact that all IPF patients, in general, IPF patients have short telomere length. So I'll walk you through this. This is age, this is telomere length. These are the percentiles in the human population. And IPF patients in general fall on the lowest deciles of the human population, whether they have the mutation or not. And by way of preview, I'll tell you that many of these patients died shortly after lung transplant when they receive myelosuppressive medications. And this one patient here died within a month after receiving a lung transplant, suggesting even early on, the telomere length may have some, this is in the blood, may have some prognostic value or some diagnostic value. So based on the initial families I saw in this so-called telomere clinic that I created, there were 12 patients at the time, we noticed several recurrent patterns. One of them is that a lot of these patients with mutations had not only IPF, but they had bone marrow failure and cryptogenic liver disease. Many of them were misdiagnosed as having autoimmune disease because it seemed like they had degenerative disease in multiple organs. Many of them received immune suppression, but instead the mechanism here is premature aging, or as I'll tell you, stem cell senescence in multiple organs concurrently that is recognizable clinically, and that has implications because in this setting immune suppression does not work. And this pattern shows a very particular inheritance peculiarity where with successive generations, not only does the disease show up earlier and is more severe, but it also evolves from being an IPF condition or a pulmonary fibrosis predominant condition in grandparents to being an immune deficiency or aplastic anemia or even enteropathy in younger generations. They tend to be smaller, and eventually younger generations acquire infertility or unfortunately die in childhood, and the mutations die out. So there are very few founder mutations in the human population because of this pattern of genetic anticipation. Other lessons we learned is if you look carefully enough, and you have a friend who's an ILD doctor, and I've had to learn a lot about ILD, families, within the same family, people have different types of ILD classifications. So the most common is IPF, and it's generally, most males acquire that. But for some reasons that we still don't understand, females acquire upper lobe predominant disease, mostly as NSIP or hypersensitivity pneumonitis. But regardless of the histology, the genetics here trump the outcome. The median survival is unfortunately 3 years. All of these patients respond poorly to immune suppression. And I'll mention briefly, as Dr. Su mentioned, that some patients get emphysema, but mostly females, and only if they smoke. So there's some peculiar things about lung physiology and the way the lung responds to the environment in males and females that have been very notable here, and we can talk about them if we'd like. So the pathophysiology here is maybe intuitive in the bone marrow. That's a high turnover tissue, 300 billion cells are made every day. So there's stem cell failure, and it leads to both myeloid failure, but also immune deficiency. And that becomes very important when the mainstay of therapy empirically has been immune suppression. But in the lung, we have shown, and I think we can think of clinical evidence of many patients who have had bone marrow transplant and a renewal of the immune system, and they still develop pulmonary fibrosis canonically. So if you introduce telomere dysfunction in the lung stem cell progenitor, at least the type 2 alveolar epithelial cells, and you take out those type 2 cells, grow them on media that allows them to generate these alveolospheres. So these are spheres that contain surfactant in vitro. You see that the short telomere, or here in this context, telomere dysfunction, the cells don't grow. And this is what we define as a senescence, where cells get stuck in the cell cycle and they can't move. And in the animal model, I think I don't show this here, but in the animal model, what we saw is in the response to senescence, there's an inflammatory response that looks identical to cigarette smoke, actually. So if you didn't know that the lesion was only in the stem cell, you might think that the inflammation is what's causing the process, but actually it's an autonomous process. And it's related to aging, so to speak, of the alveolar stem cell. And of course, the alveolar epithelial stem cells that are in the periphery of the lung are the ones that have divided the most, because in embryonic development, it's proximal to distal. So those are the cells that are vulnerable, and those are the cells that, as you know, suffer the most or suffer first in an IPF patient. So there's two pathophysiologies here for short telomere disease. One is replicative attrition, which makes perfect sense. The other one is this aging in the lung, but it's not directly related to replication because the lung is generally inert. But because it's inert, it acquires and keeps track of environmental exposures, and it's the epithelial compartment that's exposed the most to oxygen damage. It's also exposed to cigarette smoke and other conditions. So we think here that short telomere length alone is not sufficient to cause the fibrosis phenotype, but instead it requires multiple hits. So for the next few minutes, maybe I'll walk you through some of how we came about both understanding the clinical implications, but also for someone like me who was saying something different than what the field was saying, how we tried to convince people, and it was through fairly small numbers of patients, remarkably, I think, in retrospect. So a while ago, I had written this review with Liz Blackburn, and we defined the short telomere syndrome spectrum as being a med-ped spectrum. So it affects children and young adults, and also adults, but the phenotype is different, as I showed you in that pedigree. As you go from left to right, the names go from being obscure in Latin to being common and understandable in an internal medicine clinic. But nobody really paid attention at the time until this case series was published, and I was preaching, evangelizing about how IPF patients have susceptible bone marrow compartments. And these cases were gathered from around the world in Australia, Duke University, Sweden, Hopkins. These were patients who had undergone a lung transplant for IPF, and they had hematologic catastrophe. And the people who recognized the syndromic entity were actually the hematologists, not the pulmonologists at the time. I think things have changed since. Some of these patients died from sepsis, just like the patient I told you about. Almost all of them required platelet transfusions. And some of them, like this patient in particular in our ICU, he died after being hospitalized for a whole year. And this was Sonia Danov's patient initially, as we were learning about these conditions, died from CMV pneumonitis. I'll come back to talk about CMV. This is a patient at Duke who acquired invasive aspergillus in the native lung and had a right lung transplant. So what is it about the telomere that predisposes patients to these viral infections? So as you know, the immune system ages, but it really doesn't age in everybody the same way, and it doesn't. But when we studied young adults with short telomeres, we found they had all the hallmarks of aging that old people get. In fact, they were much more severe than people who are 50 years older than their age. But if you think about it, this was the comparison I just showed, and this is, let's look at this four-way comparison. Young people with short telomeres are prone to immune deficiency, and it can be severe. But in IPF patients, they have both the aging against them and the short telomere. So you might expect that their T-cell repertoire might be compromised because they lose the memory with aging. And I think I'm going to try to convince you that in particular, they use memory for herpes viruses that are latent, that require so much work from T-cells to suppress. So when you take T-cells from the blood of all these four groups, and you look at how many unique repertoires are in each group, you see that the IPF patient with short telomeres has basically almost no repertoire. They've lost all their T cell unique immunity, and therefore, when they are immune suppressed, that can cause catastrophe. And the telomere length is a surrogate marker for this fancy sequencing experiment. And of course, at the time that we were working on these, we were just talking about the Panther trial, the NIH, this is one of the few NIH-funded clinical trials in recently, where they randomized patients with IPF to either azathioprine, prednisone, or placebo. And that trial had to be stopped early because there were 8 deaths in the treatment arm and 1 death in the placebo arm. So this kind of might make sense to you now that you appreciate that most IPF patients, at least half of them, have severely shortened telomeres. The other piece of evidence came from the transplant observations. And this was work we did with University of Pittsburgh and John McDyer. If you look at IPF patients post-transplant, they have a much higher risk of CMV viremia compared to non-IPF patients. So these are all patients with lung disease. But something about the IPF that predisposes to the recurrence of viral infections. So if you look by telomere length, the highest risk group was the group that had telomere length below the first percentile. So that's extraordinarily short telomere length. And I'll go back here and tell you that the highest risk of CMV disease and CMV-related mortality and morbidity is when you take a patient with IPF who's CMV negative and expose them to a CMV positive organ. So all of these clinical observations, I was never into diagnostics. I never had wanted to do anything related to laboratory testing. But it seemed like having a test would be helpful for identifying these patients, because maybe I could tell clinically, but as we were talking yesterday, I could tell more than the average person, but I still was wrong sometimes. So having molecular testing that was robust seemed needed, and this has been, a great pleasure, but also a detour a little bit in what I was imagining my career to be, because, having a diagnosis is often life-saving, and I think that's what we did, and or we were hoping to do. So the idea would be that if you have a patient who's going for a lung transplant, you can stratify them based on telomere length, and then do certain things. Avoid giving them Campath, for example, reduce the immune suppression, and avoid this CMV mismatched situation. And then the lung transplant could actually be successful. And I'm very glad to tell you that I put this figure together in 2010, and last month there's international consensus guidelines that basically have agreed that this is the way to do things, and that was just recently published for patients with telomere shortening, not all patients, but. And while we were working on generating this diagnostic test, it's laborious, it's flow cytometry based, it uses FISH probes that hybridize to the sequence of the telomere, and you run them through a flow cytometer to detect the signal for each cell. We created a nomogram of telomere lengths in Baltimore. So these were individuals who were healthy donors who were across the age group, and we compared our nomogram to one that had been created in Canada. And what was remarkable is that the two nomograms coincided perfectly, suggesting that the human telomere length normal range is really finite. And I'll come back to tell you why that is important for understanding disease at this end of the spectrum also. So the testing at our lab has actually exceeded capacity, but you're wondering why doesn't anybody else create an assay like this? And it's because there's no profit. It's because it's very robust, but very laborious also. So as an academic center, this has not been easy, but also rewarding. And I think it's an important part of our efforts to make sure that the test is ordered in the right setting, which I'm not going to talk about at length today. But this is the pattern, and 2/3 of the testing is from lung disease indications, and the rest are hematologic. And just to show you the pattern, this is a positive test. So these are individuals that we, in our expertise, claimed, noted to be diagnostic of the short telomere syndrome. They all have mutations. You see, there's a threshold here below which you never see telomere length. The cells don't survive. It's not that the assay doesn't detect, but cells don't survive when they have such short telomeres because they undergo cell death, etc. You also see that the yield of the test is dependent on age. So almost all the people who are symptomatic below the age of 40 fall in that very short length. And in this category where IPF is really, really enriched, about 70% fall below the first percentile. So that's really good. You can make the diagnosis, you can rule it out with this test. But after the age of 60, unfortunately, most of these people have died. And the only ones that remain here below the first percentile are the ones that had undergone a lung transplant. It's remarkable. So from a clinical point of view, the yield for testing above the age of 60 is lower. It's not 0, but it's closer to 10%. And if this diagnosis is suspected above the age of 60, I think we're trying to encourage folks now to do the genetic testing in addition to the telomere length. And that has its own caveats that we can talk about. So the other thing that I think I want to mention is we do telomere length testing in both lymphocytes and granulocytes, so not just in one lineage. And that's part of the utility of this assay. And these leukocyte subsets have different rates of telomere shortening. So when you plot the values, you plot them relative to a nomogram from that lineage, obviously. So here is the classic TERT mutation carrier with IPF. He presents at 60. But in the work that we have done in scleroderma and other conditions, there's a different pattern. The pattern shows that the granulocyte telomere length is intact, relatively intact, but the lymphocytes are the ones that tend to be shorter. And this is not just true for scleroderma, it's also, we haven't published this, but it's seen in patients with multiple sclerosis, long-standing rheumatoid arthritis. And oftentimes I get requisitions and I see a pattern like this and I call the physician and I say, what does this patient have? And it's like nothing. And it turns out to be psoriasis or something like that. So this is secondary shortening that is related to acquired attrition from a long-standing lymphoid-mediated process. And I think this has caused some confusion I would argue, in the rheumatology literature, because most of the studies that are in the literature combine these values. So they measure the telomere length in bulk leukocytes. And if you measure it on bulk leukocytes, you might imagine that this patient too has short telomere length. Like, it's not going to be as short as this one, but it's going to be intermediate. So people have tried to claim that short telomeres may have prognostic value in autoimmune disease, etc. I think the problem there is a bit technical, and it may be related to lack of resolution for the lineages. So in our algorithms, and I think this is going to become a standard of care, and I would argue it is already in some sense, identifying patients prior to lung transplant who have super short telomere length is really important. And the yield of testing is between 40 and 60. And should you test everybody? Maybe, but definitely the people who have idiopathic ILD, people with a family history, people with hematologic processes, people who have liver disease also. We should not find out post hoc with the complications, I would argue, in this 2026. So I'll try to summarize here, and maybe if there's time, with Dr. Su's permission, we can talk and see if there's any questions before I keep going. So 30% of familial cases of pulmonary fibrosis are attributable to this pathway. It came out of the blue, as I tried to explain to you. It came from a single family observation. How interesting that science can still happen that way, or at least I think it still can happen that way in the future also. And using this genetic finding, we were able to piece together genetic associations that nobody would have ever inferred by either looking at DNA sequences all day or by seeing patients all day. We had to integrate that data somehow in a careful way, in an open-minded way. This association in a family of pulmonary fibrosis with aplastic anemia, with immune deficiency, with hematologic disorders, including MDS, should not be missed. It probably catches only 10% of patients, but it should not be missed. So it's not sensitive. This process is driven by stem cell failure and does not respond to immune suppression. That means there are other processes also. And distinguishing those two, I hope, can be done in some cases. It cannot be done in many, many cases. We still have gray zones, but there are extreme cases where these pathways are divergent, and that's clinically helpful. And then ultra-short telomere length is a predictor of lung transplant and requires an attenuated approach, at least a vigilant approach, if not an upfront attenuation. So is it okay to see if there's questions? Yeah, please, yeah.
I'm still not understanding how immune suppression is leading to premature senescence or death. Is it mediated by infection, or is it a direct toxicity? Because you have both prednisone and then a cytotoxic medication, azathioprine. I could buy a story that the cytotoxicity is leading to premature death and maybe fibrosis resulting. I wouldn't expect it just from the immune suppression for prednisone. That should not kill cells. What is causing the...
I think we, at least in oncology in our field, we use prednisone to kill lymphoma cells all the time. So we know it is cytotoxic too, but it also impairs their function, right? So if you have, one T cell to suppress all the CMV, and then you get rid of that one T cell, it's likely that patient will have, reactivation. Either we've seen CMV retinitis, we've seen CMV encephalitis, we've seen pneumocystis. So, does that?
Another way of saying, is it mediated by infection, or is it a different pathway? The immune suppression, is it causing a different pathway that leads to premature fibrosis?
Sorry, can you say that again?
Sure. Immune suppression will lead to a premature fibrosis in people with shortened telomeres. If somebody with IPF has shortened telomeres.
I got it, yeah. I don't think the immune senescence leads to the fibrosis. I think both exist independently. So if you were to do a bone marrow transplant in a child, they will grow up to develop pulmonary fibrosis still, on average about 15 to 20 years later. So it's not the immune senescence that's leading to the fibrosis, it's that it's a syndrome, and the treatment of one will affect the other. The other example is when they used to do bone marrow transplant for these patients using busulfan, all those patients died, even though they had no a priori lung disease. So I think it's a fragility in both organs. It may or may not be clinically evident, but if you harm one, you could, or it won't work, but you can also bring out the phenotype in the other organ.
So I want to congratulate you. It's a great talk. Thank you so much. So I have two questions actually. First, is that, so to check for the telomere, is that part of the routine testing now that has to be done before the transplant? Or is that something that we have to ask for?
I think the word is getting out. Like, I think we have, in that graph that I showed, we have about 200 users. The heaviest users are the heaviest lung transplant centers around the country that have unfortunately seen the complications and they don't want to see them again. So they've integrated that into the transplant. I think if we test all ILD patients, probably we won't be able to keep up with the volume. So we have some algorithms, and I'm happy to share them, as to try to refine the testing as to who to test and what are the negative predictive markers clinically, including high titers, definitely the myositis patients, that's clinically an exclusion. There's, of course, exceptions, but I think we can try to weed out a subset and then pick the highest yield testing. And then the transplant people will do their own testing. I think that maybe, at least for now, until...
We have to still mention it.
Yes, I think some centers, it's protocolized. And some centers are learning how to use it. So it used to be about 5 years ago that there were advocates at a lot of institutions, and when those advocates left, people didn't believe, the rest of the group didn't adopt it. But I think the pressure is increasing for this to become a standard integrated test, and hopefully other labs can help us. Yeah, please. Yeah.
This is a fascinating presentation. As a hepatologist, I'm also aware of work that's been done on telomerase mutations, and their implications in hepatic fibrosis and cirrhosis progression.
Yes.
And they have implications also for liver transplant. I think you touched upon it when you were talking.
Yes.
So this is an amazing field that continues to evolve.
Thank you. I think that I didn't get, emphasize that, but at least 10 to 20% of adults have require or develop end-stage liver disease. It often manifests as hepatopulmonary syndrome. Oftentimes it co-occurs with the pulmonary disease, so that requires dual organ approaches. But the lung is still the dominant phenotype. And it explains probably about 1 to 5% of all cryptogenic cirrhosis. So it's not as big as the lung. I think that's, but it's still there. Yeah.
So, Dr. Armanios, do you mind just repeating the questions?
Oh yes, sorry. Yeah, thank you. Yes,
So,
please.
thank you for the great talk. Most of our rheumatic autoimmune diseases are T-cell driven, where T-cells are hyperactive. Can we safely assume that our patients do not have short telomeres, or that T-cells are hyperactive?
If the question is, if a patient has rheumatologic disease and has clearly evidence of hyperactive T cell, can you assume that it's not the short telomere? I'm going to oversimplify and say yes, if you're sure. But the question is, how can you be sure? Now that we know this phenotype, you might be able to. So I think definitely I would guess for sure scleroderma, that's a very different pathophysiology, and I knew that already before we did the study, but John Varga convinced me to do it, and that's how we found this lineage-specific shortening.
And what about the B cells? Do we have any data on the B cells?
Let me take that question in the next part. I think it's not as severe. I think T cells are very vulnerable to short telomeres because we have to maintain memory from childhood to end of life, right? The viruses, especially that we see in varicella, et cetera. So, but B cells are less replicative, vulnerable because they just produce things. They don't have to divide as often. It's the simplistic way I have. Sure.
So in terms of immune suppression, you mentioned that people with short telomere, we have to go easy with immune suppression. Have we established the guidelines, how much of an immune suppression we have to do?
So I think technically ILD that is caused by short telomeres is not going to have clinical benefit related to immune suppression. So I think we try to avoid that, and when we see the patients in our clinic, we try to get them off of prednisone or azathioprine, et cetera, because they are vulnerable, and I think the benefit may be temporary and patients feeling better as you know better than me with steroids, but I think the long-term impact is not clear. In the lung transplant setting, it's more complicated, and I think it's only the subset with super short telomere length where a modification is needed. Great. Thank you so much for these questions and this engaging. Sorry I didn't repeat the last question. I forgot. Okay, so this was really an interesting piece of data related to the upper boundary of telomere length. Is there pathology on the upper boundary? And that was, of colloquial and public discourse interest because there had been many books, fiction, newspaper articles that claim, short telomeres are bad. We should all lengthen our telomeres. It's really good. And that doesn't, it might be nice to talk about, but it didn't make sense clinically, especially in light of these data. And as you probably already know, this has been in the press and in the public conversations, especially a few years ago. This attempt to manipulate telomeres just because you can measure them to prevent death, maybe, and at least prolong life. So we came at this during the pandemic, and the gene here is not TERT. The gene is known as POT1, and it's a gene that binds the end of the telomere, and it prevents telomeres from elongating. And it had been described in multiple cancer-prone families, but people thought they were getting cancer because cancer is premature aging, and therefore they had short telomeres. So we collected a group of 5 families during the pandemic. One of the families had many physicians, and they could draw their own blood over a Thanksgiving holiday. And they just said, study us. And others in this group were also healthcare providers. And not surprising to me, but surprising to many people, they actually had super long telomere length. And when I met these families, initially by Zoom and eventually in person, it was very clear that they looked younger than their age, as opposed to the initial proband that I told you about. And people in their 70s hardly had any gray hair. And one of them I met at a meeting, and I thought he was a graduate student, but he actually had been a physician scientist, had his own lab, etc. The price of that long telomere length, though, comes out in this risk for neoplasia. So these patients are prone to having masses or growths and cancer in multiple organs. Let me say in all organs. This is a melanocyte aggregate. It's not a melanoma in the eye. This is a goiter. Here's a kidney cancer that was multifocal, and this child died when she was 7 from glioblastoma multiforme. And you can see here the prevalence of these cancers. Melanoma is most common, and that's why the melanocyte growth is what prevents them from having hair graying, because the melanocytes live longer. But also, they had these blood disorders or blood cancers, and that was of great interest to me because we can access the blood and we can study the blood. And you could see sort of like the whole progression of benign lymphocytosis to acute and chronic leukemia. So we tried to study this using this phenomenon of clonal hematopoiesis. So as you know, as we age, we acquire clonal mutations in our blood, and about 20% of us, if we live to be old enough, have at least 4% of our blood represented by one hematopoietic stem cell. And this is thought to be a premature aging phenomena, and its etiology had been unclear. So when we took the relatively small group of POT1 mutation carriers and tested their blood for these clonal mutations and compared it to the relatives who don't carry the mutation, they all had it. In fact, everybody after the age of 60 had it. And we've done this, and we have another paper that was just published last month where you look at the lymphocytes, and the lymphocytes have clonal fusion genes that are also seen in lymphoma. So let's just think for a second, this is supposed to be a youthfulness syndrome, but the phenotype is paradoxically premature clonality or premature aging. And to trace the history of these mutations, we took the blood and we generated colonies, erythroid colonies in the lab, and then we sequenced the genome of these single cell derived erythroid colonies to see how long these mutations have been in these adults. And in this phylogeny, you can see that some of the mutations, using algorithms that date them, actually arose before people were 3. So how does a mutation that we acquire in utero or in the newborn period live to remain in someone who's 74? Only if the telomere length is long. And this finding aligns with genome-wide association studies that had identified clonal hematopoiesis associated with variants that lengthen telomeres, and on the other extreme, variants that shorten the telomeres with IPF risk. So, and in the recent study, we measured telomere length longitudinally in these individuals with POT1 mutations. So in granulocytes where there is no telomerase, this is how aging happens. So this is the distance from the 50th percentile, and you see that in both compartments the telomere length is long. But look what happens in the lymphocytes. The telomeres don't shorten. And that's perfect. I mean, on some level, you would think that's perfect if you're trying to develop a cure for aging, but obviously the consequences are not clinically what you might imagine if you just look at cells or under a microscope all day and never think about a patient. Because the lifetime risk of lymphoma and B-cell malignancies is 100% if these patients live long enough. So this is a common pathway that predisposes to all types of lymphoma, most commonly CLL, predisposes to familial CLL, and myeloid malignancies in some cases, and remarkably in some cases both myeloid and lymphoid malignancies, myeloproliferative disease. So just to simplify and I think this is remarkable. You know, normally the telomere length shortens as we age, and that is helpful in that the acquired somatic mutations we might get are weeded out. They die out. But in this case, and this is actually what happens in short telomere patients, in general, they have lower risk of lymphoma and other malignancies except in the blood. But in the long telomere syndromes, the mutation arises and it just keeps going. It just keeps going, and lymphocytes are particularly prone, B cells in particular are particularly prone because they have telomerase, and therefore the opportunity for the telomere to lengthen when there's no POT1 increases. So I think this, paradox is really informative, and it comes from really basic bedside observations that I mostly learned about when I was a med-peds resident, combined with fairly simple genetics, but it explains a lot of things. Here's premature aging. It does not explain all sorts of aging. It primarily explains lung aging, immune aging, bone marrow aging. All other kinds of cognitive, vascular, that's not on this simplified scheme. But you see the opposite exactly. B-cell neoplasm, myeloproliferative disease. Here is early hair graying because melanocytes senesce. Here melanocytes live longer, and therefore the patient or the person looks younger and does not gray. So I'll summarize here, and then we can maybe have room to talk again. Ultra-long telomere length predisposes to this cancer-prone state. its underlying biology is paradoxically youthfulness. And there's 4 other genes other than POT1 that predispose to this that we and others have published on. And these are probably, when all is said and done, are going to be some of the most common cancer-prone syndromes. Thankfully, the cancers that these patients get are often indolent and treatable. Long telomere length sustains clonal mutations, and this predisposes to all sorts of lymphoma and suggests that different types of lymphoma have shared heritability. And I think we talked about this, so I'll stop here and thank you, and I'm glad to continue the conversation.
I have a question. Excellent. So for these patients with IPF, it's familiar, you know. So as a preventive measure, if we measure the telomere and the descendants and we find a short telomere, since we have the reverse telomerase, isn't it a good idea to lengthen the telomere?
No.
Make a study, new drugs that will lengthen the telomere in these patients, in these families?
Let me try to repeat that. Can you prevent IPF in someone you know is going to get IPF, and is there a way to lengthen the telomere? I think there are so many breaks on the system because it evolved for a long time. There's at least 7 different breaks on how to lengthen the telomere. So some people have suggested, oh, you can just introduce telomerase intratracheally and everything will be fine. But the problem is, first of all, telomerase only elongates when cells divide. How are you going to make cells divide? And even when it elongates like 2 or 3 repeats. And by the time someone has IPF, they're 50, 60 years old, they've acquired all the secondary hits that may have driven that. So I think it's not so simple. It's not a monogenic disorder that is dissociated from aging. And can you erase aging? Can you erase breathing, basically? So I think we focus our efforts on avoiding harm, not overscreening, not exposing these people to too much radiation, being able to jump in when we can predict when the symptoms will arise, refer them to transplant on time, etc. So that's my take. I hope I answered both of those questions, yeah. And I think I worry that the paradigm of early intervention is too easy, let's give them antifibrotics. I don't think we have evidence to do that, and I think those drugs are toxic and probably do not help this pathophysiology. Should we take in the back? Yeah, sorry.
I forgot to mention this earlier, apologies, but if you want CME, you have to text 31639.
31639. Please, yeah. Yeah.
You mentioned a background in ethics yesterday. I was wondering if it had ever come across your mind implications ethically about this sort of testing. For example, because of the association with malignancies, discrimination by an insurance company to prevent coverage, or instead of using this as a 3-lung transplant testing for good or worse to deny patients.
For the long telomere or the short, yeah.
Yeah. It seems like you've identified
Tough question. The question is, what are the ethical implications and how do we approach genetic testing in asymptomatic people, including children, I'll add. I think there's a bit of a divide, and it's very large, between discovery science and application. And I think we talked even over dinner yesterday about how there's a profession, genetic counseling, that is trained to address patient questions and family questions and the burden and whether you should test at all. And I think those conversations are very long with patients and somewhat frustrating to patients, right? Because we know what will happen, but we can't prevent it. And IPF, it's a little bit easier because we know when it will happen. But with the cancer question, some people advocate whole body MRI, for example, and the contrast in MRI chronically can cause neurological sequelae, theoretically at least. So I think the gaps on the front end of some of this science are tough. And I think, some people believe that you should test everybody. I don't believe that, and I don't think, especially because we could cause more harm than good if we identify patients too early. So I think that's an ongoing conversation. I think the best thing we can do, though, is at least make sure that the patients who are in front of us have a diagnosis, and then at least worry about that later. And that's very relevant for the long telomere because they are so liable to second malignancies. So if you can avoid radiation in a breast cancer patient, if you can avoid chemo that would not precipitate leukemia onset, that would be great. So I tend to work in the areas that are very clear cut, but I think the question is very, very appropriate, and we need to talk about it. Yeah, thank you.
There's a question from Dr. Sundaram wanted to ask a question online.
Hi, thank you so much. That was a wonderful talk. I have a family of IPF, a family with 3 brothers with IPF, but all of them over the age of 70, in their mid 70s. One of them actually just passed away. And he was referred to get the telomere length testing, but the patient mine refused to do it. The question, I guess, is, what are the implications for his family, his kids, and so on? And, is it worth having a discussion with him to really push for the testing to see if his kids are at risk for developing pulmonary fibrosis?
Thank you, Dr. Sundaram. So I think based on the age, one would predict that there's a 30% chance that this patient or family would have a mutation in one of these genes. And it's much more informative to test an affected person than an unaffected family member, because at least they have the phenotype. And the telomere length testing in this case is not as useful, or maybe should be an adjunct with genetic testing, because the sensitivity in people older than 60 is quite a bit less. So that's the first thing I'll say. What do we do? Let's say this family's children are very adamant about finding out about their risk. In general, we have an extensive genetic counseling visit, and if they choose, many people after that choose not to be tested. If they choose to be tested and they are positive, we often recommend a dry CT after the age of 50. And if they have disease, we refer to ILD for them to be monitored clinically. I think we focus a lot of our efforts on education and telling people if you have symptoms, go to the right place. I think implementing a genetic testing paradigm for such a common condition is not accessible, unfortunately, in most of the country. And there are places that have created clinics, but I think they probably also over-test and over-promise what we can do. So that's what I would say. I think I would educate. I would consider a referral to genetics for the testing of affected people, and then a counseling visit for the children, if they're interested.
Thank you so much.
Thank you very much for the wonderful conversation. Thank you so much. I hope that's what you were looking for. Great talk. Yeah. Great talk. Thank you so much for your message. It's a pleasure to meet you.
Thank you. I'll see you in about an hour.
Thank you so much. It was a pleasure to see you. Sorry I worked
Oh yeah. It was very great talk. Nice to meet you. Bye-bye.
Armanios جورج عبد السيد طبعا مصري كبير واخويا كان اول كانت تركيز القبطية في أمريكا أبونا غبريال سيدنتي فين. That was my dad. Are you related to Deborah Armanios? Okay, they live in New York. So أنا hepatologist, gastroenterologist. Yeah. He was a good man. He served for 23 years. 1970, I listened up to 13 years old at the time, and he passed away in 1993.
You're taller than him.
Yeah, a little bit. انت ساكنة في كليفلاند؟ كيمل دي فين في عندك هناك بتاع ال FDA مكاري ماري مكاري. Why aren't you a member of COP2COM بتاعت نادي الأنيس? You should come. I'm going to recommend that we have you as one of the keynote speakers.
Thank you.
For society. Thanks.
Dr. Armanios, nice to see you again. Thank you so much.
Sorry, the questions were not.
No, that's okay. My question about...
Kirsten, you'll erase my talk, yeah.
I'm sorry?
You'll erase my slides.
Yes.
Yeah, thank
Okay,
you. Sorry.
wonderful. Dr. Law had actually asked one of my questions